This is our first live, so please be gentle. Obviously, this is not in the office, this is in my home, so please excuse if dogs or children come in. Everyone's in bed, including the dogs, so we should be okay, but just in case, I may need to dash out and sort somebody out. So, this is, I'm just going to introduce Jo. This is Dr. Jo. She's been kind enough to join us in this live to answer some questions about going to the ED. So I just want to let Jo give you a bit of background on who she is and what she's done up until now in her emergency medicine career. So thanks for joining us, Jo.
Thanks, Kim. So I'm Dr. Jo, and I currently work in quite a small regional emergency department, but throughout the last almost 20 years, I've worked in lots of different hospitals, ranging from rural-based hospitals right through to major metropolitan hospitals in major cities. And I worked in emergency medicine, but as part of my training, I've worked in a lot of other specialties as well, such as trauma and cardiology, pediatrics, obstetrics and gynecology. There's a lot of different specialties we rotate through. So, yeah.
So you've pretty much seen everything by this stage in your career.
I've seen a
Would
lot.
that be okay?
Maybe not everything, but I've seen a lot.
Yeah, great. So, we're very lucky to have Jo. We might wait a few more minutes just for a few more people to pop in. It's only 3 minutes past 8, so let's find out more about Jo. What are you doing on the weekend?
I'm working this weekend.
Oh.
I'm running a marathon next weekend.
Ah, that's what I was getting at. So you're running a marathon. How much training is involved in that?
A lot of mileage. Running almost every day. Bit of swimming, bit of cycling, but mostly running.
Right. I shan't be running in the marathon.
You'll run the 2K with the kids.
Maybe, yeah, maybe. Yeah, right. So it's important to try and stay healthy when you're working in a stressful job, like emergency doctor or support worker, for example.
A lot of my colleagues are either ultra marathon runners, triathletes, cyclists, adventure racers.
A lot of spare
A lot of
time.
those
Do they
things.
have a lot of spare time?
They make a lot of spare time, I don't
Right.
know.
Okay. Great. All right. Well, that's enough small talk. Should we get stuck in? So, again, thank you for giving us your time to answer some of these questions. I think it's going to be really useful. I'll just preface this by saying that Jo's going to refer to the participant probably as patient, because that's the vernacular that she uses in her career. But please don't be too hard on her if she slips in client or participant. We're doing our best to have consistent terminology. So, we'll just lead off with that. So you're going to be using the word patient. Now, some of you may have been to the ED many times with a participant or with your family member, and some people may have never been to the ED, and it can be a really busy and overwhelming place. So we're going to start from the start at the most logical place. When you're thinking about heading off to the ED, before you hop in the car, what are some of the things that you should be thinking about? This is a question that came up in the group. So what are some of the things that you would be thinking about before you hop in the car with the participant to head off to the ED?
Well, I think the first thing to think about is whether that's the appropriate way to get to the emergency department. I mean, it depends on how emergent the situation is. Obviously, if it's dire emergency, you need to call an ambulance. That may be the safest way and the quickest way for the patient to get there. But in other cases where there's a bit more time and it's not quite so emergent, you will have some time to gather some things and drive the person there yourself. So I think in that situation, there's a range of things that could be quite helpful to think about bringing with you.
Now, I see you eyeing off a list. I just want to, before you go into that list so people don't feel like they have to jot it all down, we're actually going to upload this list into the group afterwards. So take notes, but don't be worried that you're possibly going to miss anything, because we'll make sure that we put it up in the group. So yes, go ahead.
Sure. So I think there's a number of things that can be really helpful to you and your and the person that you're looking after, or also things that can be really helpful to us as emergency staff. So probably the first thing that comes to mind is having some sort of emergency contact list. So the patient's next of kin, family members, primary decision makers. So if the patient is a minor or perhaps because of their disability doesn't have the capacity to make a lot of decisions in terms of consent for procedures, etc., then knowing the emergency contact list with phone numbers that can be contacted from the emergency department is really helpful to bring in with you. I think also if your client, if the client has a specific care plan that's already been formulated, and you have access to that, then bringing that in can be very helpful. Sometimes not so much in the emergency, but if patients are admitted to hospital, then having that kind of information in terms of their specific needs and preferences and that kind of information can be really helpful to the staff on the ward and people who are looking after them 24/7. An example of that would be patients who come in from residential aged care facilities will usually come in with paperwork, and some of that paperwork tells us a lot of things in terms of how many people are required to transfer them, what mobility aids they need, what their dietary preferences are, other things that are useful for people to know who are taking care of them. So if you've got something like that, then that can also be helpful to bring in. I think what's really helpful to us in the emergency department is the information we're trying to gather, which is what are the patient's medications. So if you can even just bring in all the medications in a bag or a box, that can just be great. I'm happy to just go through all of their medications. It's when people don't bring them in or bring in individual loose pills, we can't identify what they are. It's really difficult for people to recall all their individual medications with dosages and how many they take and when. So having either the medications themselves in the boxes coming in, or having a detailed medication list, or some people have like a Webster or a blister pack that can just be grabbed, because that also has, even though the pills are loose within the pack, they have the information on the back in terms of exactly what they are and the dosages. Or there's also sometimes people have a roll of medications that is a way of packing from the pharmacy. That's also helpful to bring in. So that is really useful, and it also gives us information about their medical conditions by seeing what medications they're on. And also sometimes people will even bring in a health summary in terms of all the medical conditions that they have that are current or perhaps relevant things from the past. And sometimes those health summaries will also have the names of their specialists and contact details. So those things can be really great, because I think a lot of people are under the impression that emergency staff just have access to some sort of central location where they can find all the information about patients. And unfortunately, in a lot of situations, that's not the case. In some hospitals have everything electronic, and that's fantastic, and you can access a lot of stuff. Other hospitals sometimes still have a lot of paper charts, and sometimes they're not even on site, they're off site. So we don't have access to them. It's really difficult after hours if we're then not able to contact general practices, specialist medical rooms, and pharmacies to get that information. And it saves us a lot of time in hours if you can bring that information in, and we're not making multiple phone calls and asking for faxes and emails. So yeah, that's something that I really appreciate when people bring in. So it can be very helpful, and it can be very helpful to communicate a lot of information quickly, a lot of detail as well.
Sorry, I just paused there where our comments aren't working, but our somebody from the office is able to see the comments. So I've got a comment from David Collum that we will get to. It's just that I can't see them here on our thing. So first live. Sorry everyone, but we'll try and come to the questions. So if you see me looking down, that's what I'm doing. Sorry, go ahead, Joe.
Oh, that's okay. The only other medical information that is sometimes really helpful is if the person has recently had a hospital admission and there's a discharge summary from the hospital. Again, sometimes we can access that, sometimes we can't. The other thing to say is I work in a hospital where there's often a lot of visitors from interstate or even overseas, and if they don't bring things in with them, sometimes it's really quite difficult to access information from interstate. So yeah, those are the things that are particularly helpful. So medications, detailed information, medical specialists, discharge summaries, and possibly health summaries. If that information is available, it's just great to bring it in. If it's not, well, then you can't. So then I think the other things that are very helpful for you and for the patient, communication tools. So I think pretty much everyone carries a mobile phone around on them these days. I think having a mobile phone that's either charged or bring in the charger is really helpful with, a saved contact list in your phone for that patient if possible. I think it's a really important thing to say to bring in the charger. There's often long waits in the emergency department, and one of the most common things we get asked is, do you have a phone charger for my specific phone? And a lot of the time we don't. Some hospitals, in fact, in some waiting rooms, they actually have charging stations, but in other places they don't. And if you're in the emergency department for a number of hours, you may need a charger. So that's something that can be really handy to bring in with you. Also, if you're if the client is needing some sort of communication device or communication board in order to express what they're trying to communicate, express their wishes, express their needs, then it can be really helpful to bring that in as well, particularly for non-verbal clients. And then there's just the other things to think about. In a lot of situations in the emergency department, it may not be appropriate for the patient to be eating and drinking, but you can always ask. And certainly there's times where you're there for hours. And so it's handy to bring some snacks for yourself. And I think for the patients, it's handy for them to have potentially some snacks on them, particularly if they're not really that fond of hospital sandwiches and Arnott's biscuits. There may not be a hospital cafeteria or even vending machines in some places. So having some snacks that the client prefers with you, just in case, and some water.
If you like international roast instant coffee, then the ED is the place for you.
Yeah. So that's something to think about. And then in terms of other things that are useful when they're potentially long waits, I think some sort of sensory items or fidget toys, that kind of thing, can be very helpful in decreasing anxiety and dealing with waiting for a long time. Any mobility aids that the client may require, and also just some entertainment. Headphones, some music, that kind of thing can be useful for managing long waits as well.
What about continence aids? Should people bring their continence aids with them, or should they expect that kind of thing will be available at the hospital?
Again, I think this question probably depends on which hospital. I think some places will have a lot more resources than others. I think the best thing would be just to make sure you have some of your own in case they don't have some there, or in case they don't have ones that are the most appropriate.
So sorry. Now I've got the thing working. That's great. Thank you, Joe, for answering that question. I think we might, just off the back of that question, well, first of all, I want to say hi, Cindy. Hi, Anna. Hi, Nicole. Hi, David. Hi, Lisa. and that's all I can see because I don't know how the rest of it works. But you guys have commented. So David has asked a question here. I'm just gonna read it out. I'm a deaf support worker, and many of my clients are deaf. Often when we need to get to the hospital, we often face that there's no Auslan interpreter available to assist with communicating with hospital staff. Do patient records show that the patient is deaf and needs an Auslan interpreter? Or at least the system should have a pop-up message to call for an Auslan interpreter, especially in an emergency situation. This would save an awful lot of time if the interpreter is called and booked while the patient is in transit to emergency departments. Can you comment or talk about that?
Yeah, that sounds like that would be really handy. I think if patients are in transit to emergency, we often don't. I don't know which patients are there until they're there, unless we get some sort of pre-call usually from the ambulance or from a GP who's sending that patient in. I certainly know that some deaf patients that we have that come to our emergency, we do have pop-ups that when we click on their name on the computer, a little pop-up will come up. There are, in terms of interpreters, I think probably different states and different hospital services will be different in terms of how you can organise that. I certainly know that a couple of the patients that come to the emergency department I work at, they sometimes arrange their own. They have a way that they can do it and Skype the interpreter in the department. I think they've been there a number of times before, so they've kind of got it down pat. But then that they actually organise that. I think different places will be different because it's the same or not same, but it's similar for language interpreters. There's often phone numbers we can call and get that arranged relatively quickly.
Yeah, okay. So I guess there's no perfect answer because an emergency can happen at any time, and it's going to be a bit of a team effort between the person who might need the Auslan interpreter and whether or not the hospital has that in place. Okay, so where are we up to? I've lost my place a little bit. Okay.
Do you have any other questions?
Yes, I do have another question from hi Chrissy. Was it Nicole? Somebody asked a question about what's available for patients who might be schizophrenic who might not be able to be in the ED or in a busy environment, but we're going to come to that I think in one of the later questions. I think we kind of get to that, so we'll pause that one for now. Our next one, otherwise we'll just get totally off the list. Our next one is how can a support worker visit or see a participant to reassure them in emergency situations, especially if the client is vulnerable and has no family nearby? So I think this question is sort of asking, as a support worker, am I going to be allowed in? I think that's kind of at the heart of that question. How can a support worker visit or see the participant?
Sure. I think certainly in the departments I've worked in, it's very, very helpful if there's a support person there. So if it's the support worker and if the patient has a disability, which means that they may not feel comfortable being there on their own, or that they may not be able to communicate everything that they would like to about their situation and their needs and what they're there for, then having the support worker there is really helpful to the patient, but also to us. So I can't see why you wouldn't be involved in the triage process. During the height of COVID, that's where things were difficult in terms of managing the number of people in the department, and there were times where only the patients were allowed in. However, that wasn't the case for children. They could always have one parent or guardian with them, and certainly in the departments I've worked in, when there was somebody with a disability that required another person to be there, then there was no problem having that other person there because it's necessary and it's very helpful to us. Otherwise, our job's really difficult if we're not able to work out, what the problem is and what we need to do about it. So I think it's just really important to identify yourself and say who you are and what your role is, because I guess we get so used to people coming in with a relative or a parent that sometimes assumptions are made. And it's better to tell us who you are so we know and that can just be really helpful. We certainly, would prefer your help than to say, no, you can't come in. So I think I think we really value the input from a support worker, as long as that they have consent from the patient, that they can come in and be part of the assessment. Then
I think I forgot to sort of start off at the start some of the questions and answers. I think Jo's going to answer them with the assumption of consent, that consent for the support worker to be present and to share information has been ascertained. So at no point is Jo or I'm not going to be saying, the support worker can just come in willy-nilly. There's obviously consent involved in that process. So, we've assumed that that's happened. Okay. What training do triage staff receive to recognise, support and accommodate the needs of patients living with disabilities?
So I guess the first thing I need to say is I'm a doctor, and doctors aren't necessarily involved. Most of the time they're not involved in the triage process. That's the role of specific nurses. And the nurses who do the triage process go through very, very involved and specific training in terms of how they do that. So I asked a couple of my nursing colleagues about this, and from what they said, there's not specific training they get in terms of managing people with disabilities, because the triage training that they get is meant to encompass every type of patient that presents. So I guess the important information there is a specific training that they go through to be able to do it. It's not just any nurse on the floor. It's somebody who's been trained in the process. That's.
But so you're saying as part of their training that they receive for triage?
Yeah, I think they should be. I mean, they're trying to accommodate the needs of anybody who's in there. So if that means that there needs to be another person in there that helps them to communicate what the problem is, then that shouldn't be a problem.
So on from that question, and tying back into the question about, say, for example, a person with schizophrenia comes in. So what can be done if somebody's coming in and they're going to really, really struggle to be in like the busy waiting room that might be loud? There's probably a million things going on depending on which one you're at. What can be done to kind of accommodate the needs of people, such as somebody who does have schizophrenia or an autistic person who might not be able to cope in that environment for a long period of time? What happens then?
Okay, I think it's probably important for you as a support worker to mention that to the staff when you arrive, just so that they can be on the lookout and see whether they can, if it's possible, to bring the patient into a treatment space earlier than they would. Also, certainly where I work, the waiting room is not that big, and a lot of the time we're happy for people to sit outside, especially if it's nice and sunny, or if it just suits them to sit outside just around the corner, and we can just go out and grab them when it's their turn to be triaged or to be seen. So we don't expect everybody to be sitting patiently in the waiting room. There's obviously other things, like if people want to bring headphones, other things that will help them manage, then those could be helpful things to bring in with them. But certainly I think it's just about communicating with the staff if that's going to be a problem. And as I said, they might be able to accommodate you somewhere else within the department, or just waiting outside if that suits you.
Okay. All right, next question. Going really well. You could be like one of those TV doctors. You could be like Dr. Chris Brown, except he's a vet.
Yeah, I'm not sure about
that. As a support worker, will I need to make important decisions on behalf of the client, like consenting to procedures and things?
So, no. So this is where patients who have capacity to make those decisions for themselves, they make those decisions for themselves. Patients who don't have capacity to make those kind of decisions because they're a minor, potentially because of some sort of cognitive impairment, or because they're maybe an older person who has dementia, then usually there's other decision makers that have already been decided upon. So that might be the next of kin. It may be somebody who has enduring power of attorney or guardianship. It's often called different things in different states, but we certainly don't expect, and you can't legally as a support worker be making those decisions. I think in a very, very emergent situation, there's times where we don't have time to get consent and it's an emergency, so we'll treat the patient in terms of the appropriate way. But there's other times where obviously there's, we require informed consent before we begin procedures. And that's when it's important to have that emergency contact list. So often I've made phone calls to somebody who's not in the vicinity. They might be interstate or somewhere else, or not able to come to the emergency, but they're the decision maker for that patient, and we have the long discussion, and the informed consent can happen verbally over the phone in that situation. So support workers wouldn't be expected to make treatment decisions about a patient.
Yeah. So that's definitely not part of their role in that situation. Was there anything more on that question? I don't think so.
I think the other thing, and I guess this could be part of paperwork or documentation that potentially could get brought in, and it's something that we usually just see for older patients, but there are certain documents like advanced healthcare directives, or sometimes there's other, that's a legally binding document, but there's other ones like statement of choices that we have in Queensland that is not legally binding, but it certainly provides us with information about the patient's wishes if they're in a situation where they then can't tell us those things if they're very, very unwell. So that's other information that is helpful to have, and if it comes in with them, then that helps us with decision making in the emergency department.
Okay, thank you. All right. What can a support worker do to assist in the emergency department in situations where a participant cannot effectively express their needs or concerns?
Well, I think as a support worker, or just anybody as a support person for a patient, you can certainly advocate for the patient. You can be the voice for that patient. If you can see that the person is hungry, in pain, needs to go to the toilet, and they're not able to effectively express that so that the staff know all those things, then certainly you can. Please, I think we're always rushing around in the emergency department. We can be so busy sometimes that we might forget to ask people, or forget that they've been there for hours and may not have eaten when there's no reason why they can't in some situations. So certainly you can ask whether it's okay for the patient to have something to eat or drink. If they're cold, can we get them a warm blanket, please? Ask where the toilet is, and could we assist? All those things. Sometimes patients can't press the nurse call button, or maybe too nervous or too shy or too intimidated to ask questions. So yeah, feel free to please ask us.
Yep. Okay. Because doctors and nurses go the whole shift without eating or going to the bathroom, from what I understand. And I know Lisa, who's watching, I think she's still watching, is a nurse, so I'm sure she could speak to that as well. Okay. What can be done to avoid support workers spending hours in the ED when a family member could be present after initial check-in?
I think that's where a family member should really be contacted if there's somebody else that can come in to be with the patient. So certainly you could, again, identifying yourself and saying who you are. And I've certainly had this where support workers have said to me, oh, look, my shift ends in an hour or so. Sometimes there's a changeover, and that can happen with the next person in the emergency department. But otherwise, ask us to contact, or you could contact your company, and somebody can contact the next of kin or some other family member who can come in and be with the patient. I think that's very appropriate. You shouldn't have to be staying there beyond your shift. You've got other things you need to do. So I think, just make sure.
Mm-hmm. Thanks, Nicole. I see your question there. Okay. And I think that's probably, you should have contacted your company by now if you are indeed working for a company or an independent, and the after hours person or whoever it is who manages this kind of thing should have taken it to the next stage and contacted the next of kin in the family, organised what's happening with the next shifts and all that kind of thing. So don't expect doctors or nurses to even have that enter their mind because they're not thinking about it. Are you? No. Okay. I'm not sure. Do you want to?
So this question, how does the ER handle a person who doesn't feel pain in the same way others do and doesn't know their pain can show as angry, grumpy? Is there a test that can be done? I'm not sure about a test. Look, I think a lot of the time we'll ask the patients, do you need some pain relief? I think what you're getting at, I'm not sure I can understand exactly where you're getting at, because we don't want to withhold pain relief from people. So certainly I know what seems to happen more often than not is once we chart some pain relief, or even if we don't, the nurses often will ask the patient and keep offering, and will come and find us and ask us to chart some if they feel the patient is in pain or needs something more. So sometimes we can also tell, obviously, if somebody's blood pressure's gone right up or their heart rate's quite fast. There's other physiological things that can happen when people are distressed. And that can be through, they're in pain, they're nauseous, and we do try to, work out what can we do for the people, for the patients. We don't want them to be lying there in pain or feeling dreadful if we can do something about it.
Yeah, I think that's answered Nicole's question. The other physiological signs. Yeah, thanks, sure. Nicole. Where were we up to here? Okay. What are the alternatives when a participant refuses ambulance transport but private transport seems inadequate or unsafe?
I think the most important thing is your safety as a support worker, as well as the client's safety. Don't put yourself in a situation that's unsafe. I think if you've called an ambulance and that's the appropriate thing, the ambulance is there and the client is refusing the ambulance transport, then it's usually the ambulance that will then make a decision. I think if they can see that there's that the patient's really in trouble and requires assessment in the emergency department, but if it's unsafe for them to transport, there's things that they can do and there's decisions that they can make. I think there are those occasions where they actually will have to contact the police. There's other times where they may be able to give something to the patient to help them feel more calm. I think I think the important thing is don't feel that you have to then put the client in your vehicle and drive them if it's going to be an unsafe situation. That's obviously not the right thing to do.
So that's a call for the ambulance. So if the participant is not wanting to go in an ambulance, but it's life, like they're having a heart attack, for example, you are going to call the ambulance, and then it sort of becomes their responsibility. I think that's what I took from that.
I think so, and sometimes other family members may need to be contacted, and they might be able to help persuade the person to seek medical attention.
I see your comment there, Shell. Sometimes it's very difficult to encourage people to go to the doctor. It's hard. Right. I think think we've done all of our planned questions. That's fantastic. So we're going to be doing a series of lives over the next several months, and my goal is to do them fortnightly. That might be ambitious, but we'll give it a go. So not just with Dr. Jo. I think thank you. We're going to be hearing from an accountancy firm who specifically work with NDIS and care providers. So that's going to be quite handy. We're going to be spending some time with a compliance and policy specialist who also has a background in incident management and workplace investigation. So we'll have her on a few times. Very lucky to have access to that person. She's fantastic. And she has worked and does work specifically with the NDIS, local government, private enterprise, all over the place. So she's very, very knowledgeable. We're going to be speaking with allied health professionals because some people who are new to the disability space as support workers may not really know what does an occupational therapist do, what does a speech pathologist do. So we'll try and have a couple of allied health professionals in to talk about that. We're going to speak with a senior support worker and behaviour specialist who has 30 plus years working in care and disability. So she's incredible. And I'm very lucky that she works for me in my support company, Sunshine Family Support. So she's just fantastic. And we've got quite a few more. I've got a big list. But if there's a topic or a person or a profession that you would like to hear from, just let us know. We've got a very good network, and we'll probably be able to get that person to come and have a chat. So, thank you, Dr. Jo, Celebrity Doctor.
Oh, I love it. Oh, that's great.
You could be. This could be the start of something big. So that's our plan, and just to have that ongoing rolling through the year, and we'll circle back to certain things and just try and share information in the group, which, I'm really pleased with the turnout tonight. Thank you all for your questions. Let's just have a look back. Let's see. Do you want to read that?
Yeah, I saw that one from Nicole. Will the ER pick up rather quickly that the patient has a delayed response? E.g., a question is asked to the patient, they always say yes to everything, then a few minutes later they'll respond with their true answer. I mean, hopefully we pick up on that. I think, sometimes I know I'm guilty of it at sort of almost rapidly firing questions, trying to get really specific questions answered to help me quite quickly assess what's going on. But sometimes it becomes quite clear that people need me to slow down, and they just need us to take a bit more time, and they need to take a bit more time to give us the answers. I think that's also where you as the support worker can help to advocate for the patient by just alerting us to that, and perhaps letting us know that actually they've told you something different once I've left the room or something. Just communication, I think. Because you obviously know the patient much better than we do. Mm-hmm. So that would be really helpful to us.
Okay, thank you. I'll just do one last quick check. Any last questions? We'll hang for a little bit, just to make sure there's no one last one. But in lieu of that, thank you, Jo, for joining us. Thanks for taking the time, and I know that being on camera might not be your most comfortable space. However, it does seem like you're a bit of a hit.
Thanks for having me, Kim.
No worries. What have we got here? Marsha, hi Marsha. Thank you. Thanks for that comment. Doctors don't know what they don't know. They're only human. That's very true.
That's true. I'm happy to be educated every shift. I think that I come away from every shift still having learnt something. Sometimes it's revising something, but a lot of the time I've learned something new, and that can happen each time because you see different people and you learn different things from different people on each shift. So, yeah.
Even after 20 years.
Yep.
I know Dr. Jo's got a bit of the Benjamin Button thing going on, but I think that's the aging in reverse, because I think that's
the wrinkles are starting.
She spends a lot of time inside and not in the Queensland sun like the rest of us. Doctors are only human, same as everybody, and they don't know everything. So, but they know a lot of stuff. All right. Well, thanks everyone, and yeah, thanks for turning out and asking all these questions. That's great, and hopefully in a fortnight's time we'll have another great live for you. And yeah.
Great questions. Keep it up.
Yeah. Thank you. Good night, everyone.
Thanks very much. Bye. See you in the emergency.